So what I'm gonna speak about the GP referral to our local foot and ankle service. Um, so the interference between the primary and secondary care is common in many healthcare systems, including the NHS, um, and that will evaluate the role of the GP to refer the patient to the high specialty that patient needs to be seen by. And actually, there is three criteria that we can compare the good referred to is necessity. The patient are referred to when, sorry, the patient should be referred as and when necessary, and the destination, the patient should be referred to the most appropriate place and the first time, and the process itself should be conducted well. We found there's a problem that we are experiencing a high volume of GP referral um, in all specialties. The quality of these referrals significantly impacts the efficiency of the triage process that will waste the time for the triage system and for the GP and for the specialist as well. Considering there's high referral volume that should be referred to the hospital, that should cover the clinical information and clear history and a well-defined clinical question so that we can save the time and that we can refer the patient to the appropriate service. This deficiency in referral quality leading to insufficiency in the triaging process, as I said, resulting in unnecessary delays and misdirected referral and waste for valuable clinical time for the GP and for the specialist. Our current working practice show there is um, high number of the consultants in secondary care at the moment, and now the GP are referring the patients directly to the high specialist consultant without kind of triaging or without clearance of the clinical question that should be asked to the specialist. Um, This is also true for the patient that present with a complex and vague symptom, and that will make the life of the GP harder to decide the destination and the time that patient need to be referred. But according to the Royal College of General Practitioners, they released a management booklet or kind of guidelines that we made that project according to these guidelines. Um, so the standards for that audit that we're gonna use the NICE guidelines and the Scottish Interdelegate Guidelines NICWORK, which is signed guidelines as well. Um, there is local clinical prioritization that tends to be introduced for the conditions and treatment where there is not yet national guidelines have been released. Um, the low priority policies they are determined by a forum that including the clinician, pharmacist, public health professional, and the lay people, because the low doses not allow the organization to put a blanket ban on the treatment for the condition. Um, so they adjusted that these guidelines that help the GP to refer to the appropriate clinician, and also, we decided that to put a panel that to set up and to look to the individual cases and to refer the patient at the appropriate time and the appropriate destination. Um, so optimizing the GP referral to our hospital, that will enable the patient to be seen by the right person, right time, and right clinical setup. And of course, that will increase the high quality care and optimizing the capacity across the hospital. Um, so the methodology that we use, retrospective data collection for the GP referral to our foot and ankle service, and we collected 30 most recent referrals to our foot and ankle service. Um, so the fields, they are 3-point identification, provisional GP diagnosis, history provided by the GP, GP examination findings, investigation performed by the GP, and the initial treatment started by the GP, proposed action from the GP, which is actually very, very important for the GP or to make our life easy to know what we are looking for in the referral and the clinical question which should be asked by the GP. So the results that we found that there's 10% for the referrals, they are compliant on the referral criteria, but we found about 70% they are acceptable but not compliant on that referral criteria. And we found about 20% they are not acceptable at all to according to um, the Royal College guidelines for the GP. Um, we found that the most acceptable referrals they are diagnosed by the arthritis and hallux valgus, but the API is not completed in about 80% of the referral, and the API is not even included in 20% of the referrals. So our conclusions that we found the most referrals, about 90%, were non-compliant to the referral guidelines, with just only 10% of the patient were referred according to the guidelines, and about 80% they hadn't undergone any initial investigations, and about 53% were not adequately examined by their GP, and 80% they haven't had any API evidence in their referral. So our suggestion that we can use a kind of a tool we called RefHelp is electronic referral decision aid tool um, that is that has been used by another hospital in the UK, and it shows that they can provide a good information to the GP and a good information to the specialist as well. Um, for that tool, that will include the patient history, patient details, the patient kind of initial diagnosis and investigation have been undergone to this patient, and therefore that will help the GP to refer to them appropriate time, appropriate person, and the appropriate destination as well to save time for the GP, for the patient, and for the specialist as well. And this is the example for the tool that we are gonna use it in our local service. However, the evidence suggests that the passive um, dissemination of the guidelines doesn't improve the referral quality. Um, Actually, the guidelines could be affected if we combined it with the feedback from the specialist and from the patient and from the GP as well. Um, the GP must retain the freedom to exercise their clinical expertise in order to avoid the deprofessionalism seen on the other approaches. And actually, we acted on that, and we sent a poster and send an email to the GP actually to improve the outcomes for the referrals to our service, and that has been actioned. Thank you very much for listening.